So I think we can start. Almost all people have joined. So I welcome everyone to our first International Expert-led webinar series. So we'll start with the day one first session. And it is an honor to actually have Dr. Stephen Lawrence with us, who is a globally renowned neurologist and a pioneer in conscious research. So he currently serves as a research director at National Fund in 2006, and he started being the director of GIGA Consciousness Research Unit at University Liège since 2004. And his work mainly transformed the clinical understanding of coma and related disorders, including the development of a bedside tool such as second scale. And he's currently an invited professor at the CERVO Brain Research Institute and at Canada Excellence Center. He has over 500 scientific publications and more than 300 keynote lectures delivered. And his work continues to shape the modern neuroscience and patient care. He is also an author and TEDx speaker and continues to amaze us every day with his diverse roles. So please join us in welcoming Professor Stephen Lawrence to deliver the keynote address and officially start the webinar series.
Thank you so much, Sean. Thank you all for being here. An honor and a pleasure to share with you my passion as a neurologist working in intensive care and neurorehab, but also as a neuroscientist with the different labs, starting with the team in Belgium. I founded the Coma Science Group and the GIGA Consciousness Research Unit, where we look at disorders of consciousness not only after pathological injuries to the brain, but also what happens during pharmacological coma, anesthesia, psychedelics, and physiological changes, sleep, dreaming, but also meditation and hypnosis. And I will share a little bit of what the team has contributed using functional neuroimaging. Now, as you said, Sean, I'm in Canada with the Canada Excellence Research Chair in neuroplasticity. We have open positions, by the way, so please reach out if you're interested in doing a exchange scholarship or PhD, postdoc. Also tenure track professors are currently being hired. And then I have also activities in China with Hangzhou Normal University and the Chinese Academy of Sciences. So I think I can summarize my work as using all possible neurotechnologies to help us to better identify the neurology of consciousness. And that is better understanding how we can explain your thoughts right now and your perceptions, your hearing and seeing me, I hope, and also your emotions and feelings. And that's one of science's biggest mysteries. And we have, I think, now a very different view than when I was at the university, where similar to what Ramon y Cajal thought, we considered the brain to have a limited number of neurons. We now know it's about 16 billion and that we would only lose neurons. And that is wrong. We since have neurogenesis, we can make new neurons and definitely new connections. And here you see the first drawing, which received the Nobel Prize. You see this connections, tens of thousands of interactions from one neuron to all these others, and the dots, the synapses, and that is neuroplasticity. Also from these series of webinars, if you will remember anything, which I hope, it will actually change those thousands of millions of billions of brain connections. And so those changes in brain connectivity, and I'm also serving as the editor-in-chief on the journal Brain Connectivity, and very much welcome you all to consider it, because I do think that's the true power of the brain, how a better understanding of brain connectivity dynamics can help us, and definitely those working with patients, to translate it to hospitals. For those interested, I gave a number of TEDx talks on how, of course, now new technologies help us to better document changes in brain connectivity. And this is my own brain MRI. You see the gray matter, but then inside, using diffusion imaging, we can visualize the tractography, the white matter. The colors, as you know, represent the orientation of those white matter tracts. And we use these tools to better understand neuroplasticity and functional neurological recovery after concussion, but also severe traumatic brain injury, all the way from coma to brain death, and the different trajectories, with, of course, those patients taking more time before they can have recovery of response to command communication, and then cognitive and motor rehab. So, as said, with the different labs on the three continents, we look at pathological, pharmacological, and physiological changes using all possible tools. Historically, glucose positron emission tomography, which is still one of the most direct markers of synaptic activity. Of course, coupled to EEG, using, in this case, high density 256. And I know you have a lot of expertise in that area, also with event-related potentials. We would couple that to TMS, transcranial magnetic stimulation, and then, of course, MRI, both structural and functional MRI in passive and active paradigms. And that to reduce the uncertainty when it comes to the patients we see suffering from severe traumatic brain injury, but also anoxic damage, stroke, hemorrhage. And they would come to my center in Belgium for a what we call 1 week assessment, using all those different modalities and integrating that into the clinical decision making. And I would be very happy to discuss possible corroborations in that field. I started my career studying medicine in Brussels, in Belgium, doing also work in the lab, and basically being faced with the same challenge that I'm currently fascinated by, that is trying to decode brain activity in all its possible forms and say meaningful things about cognition. And I started looking at pain perception in the rat and felt very frustrated, because we measured changes in neurotransmitter systems in a model of neuropathic pain. But of course, the rat, the animal, couldn't share what it was truly perceiving. And that is still the big challenge that clinicians working with coma and related states are facing. So families, of course, being very worried. Does my loved one feel anything? This is a famous biking champion from Belgium who came to our center. He suffered from a terrible accident while in a professional race, and he came for this multimodal assessment that helped us to better understand the capacity of functional recovery. And he now, indeed, despite the very severe external diffuse external injury, can again use his bike, and he married. And we are, of course, very, very happy, despite the initial challenges, because he came with the diagnosis persistent vegetative state, and the clinicians that sent him to us thought that he didn't feel anything, including pain. And that is very important, that we use objective measures and also validated scales. And I'm very happy that with Sean and your colleagues, you are now working on validations of the simplified evaluation of consciousness scale. There's others we developed, such as the nociception coma scale, to really try to reproduce our assessment and to put it into numbers that help us to give painkillers, in this case, in the best possible dose. And I think it's clear now that we have made some historical errors when it comes to the assessment of conscious awareness. when I was in medical school and a young medical doctor, it was considered that none of the coma or persistent vegetative patients felt anything. And it was the same for newborns. We did interventions without giving any painkillers, and it was the same for severely demented patients. They were also considered vegetative. And it's also basically the same for another condition where we have no functional communication, which is consciousness in animals. And so I gave another TEDx. You see me here with my youngest son, and we decode his brain activity, this collaboration with Human Brain Project and a company called Neurosteer, that I think is really very important to help us to reduce the complexity of what we call consciousness and make use of all those possible neurotechnologies. And then we see that consciousness is not all or nothing. It's not black or white. It's not even 50 shades of gray. It's all the colors of the rainbow. And so newborns can have their form of consciousness. There is some form of conscious awareness in animals, and that's also one of the reasons I signed the Cambridge Declaration on Consciousness in human and non-human animals in 2012, with many experts doing primate research and other experts from neurobiology and veterinary backgrounds. So it's a tremendous challenge to come up with a explanatory theory when it comes to consciousness. And still, as clinicians, we need to somehow quantify, which is in practice done by reducing the complexity of consciousness to two main components, which is first the level of consciousness or wakefulness, which is quite straightforward. At the bedside, we assess it through looking at eye opening. And if we fall asleep, our level of wakefulness or arousal of vigilance goes down to the point in slow wave sleep where we have no longer content of consciousness, which is awareness. And already you have a notorious exception there in REM sleep, rapid eye movement sleep, where you look asleep, unconscious from the outside, and yet you can have that very vivid oniric activity when you're dreaming, and especially in lucid dreaming, which I think is a very interesting dissociated state that can help us to identify the neural correlates of awareness. So patients in coma, as you know, can by definition no longer be awakened. They will never open the eyes, even if we stimulate them auditorily or with noxious stimuli. The same for pharmacological coma or general anesthesia. And then in the 50s, when we had the artificial respirator and a new discipline that is intensive care, some patients with very massive brain damage survived, opened the eyes, but only showed reflex movements. And that was coined persistent vegetative state. And I would please ask you to consider to no longer use that terrible word, vegetative, comparing human people to vegetables. So we, with the European task force that I coordinated, proposed a more neutral, descriptive term, which is unresponsive wakefulness. So the name vegetative state is now obsolete and replaced by unresponsiveness, because that is basically what we see and what we do at the bedside. It's making measures of the content of consciousness or awareness by making inferences based on the motor response, asking people to make a movement and then making inferences based on the presence or absence of that response. And there are some other examples in neurology, such as epilepsy, absence seizures, or complex partial seizures, where patients can have still some motor reflex autonomic activity, but fail to have response to command. Also sleepwalking in slow wave sleep, when people would start moving but not answer simple commands. And then it became clear actually in the past decades that some of these patients we thought were vegetative or unresponsive in reality were what we call minimally conscious, or maybe we should say minimally responsive. And some showed response to commands, and that is what we coined MCS, minimally conscious state plus, and others failed to show response to command but did show movements we don't consider like reflexes, such as smiling when their loved one is in the room and not when it's a caregiver. Can't say it's a reflex, but it's all you got. So they would smile or cry contingent to specific emotional stimuli, or they would orient to pain or show visual tracking. So this is called MCS minus. And then, of course, there's locked-in syndrome that you know are patients who recover from coma, open the eyes, but they're fully paralyzed. They hear and feel and see everything, but they can't control any muscle except for some small vertical eye movements or blinking, hence the word locked in syndrome. They are conscious but locked in a paralyzed body, classically caused by a ventral pontine vascular lesion. So we have this interaction between the level of consciousness wakefulness and the content of consciousness awareness, and you see this trajectory of recovery when the ascending reticular arousal brainstem structures lead to recovery of wakefulness, and then in some cases recovery of cortical activity. But when I started in the 90s to look at neural correlates of consciousness, some said that there is no neural network that is critical for awareness, and considered it just to be a global capacity of overall brain activity. And so we started looking at the brain's metabolic activity using fluorodeactive glucose, where you can inject a labeled sugar and then you measure using PET, positron emission tomography, the activity, the energy use of those billions of neurons. And you have these artificial colors. You are now awake and aware, and you have this very high energy use, actually higher than any other organ for its weight in your body. We looked at brain death, and then you see this empty skull sign. There's only activity in the skin surrounding the brain, but none in those billions of neurons. Deep sleep, we were the first to do metabolic imaging. In sleep, deep sleep, you see this massive global reduction, overall about 60% of waking values. In REM sleep, paradoxical sleep, something paradoxical happens. You have this activity that is very close to normal waking, yet you look completely unconscious asleep. We tested several anesthetics. Propofol is shown here, where when you give it up to the point that the patient no longer give response to simple commands, you have again this massive global reduction. You stop the drug, and then overall brain activity resumes, and you have recovery of awareness. So this seems to go with the idea of the time that there is this overall threshold. If activity drops below, you lose awareness, and then when it recovers, you recover awareness. But I think that one of the results that were very important from our team was by studying coma and especially vegetative unresponsive wakefulness, where we saw that there again is this massive global reduction in overall brain activity, but when they recovered, as you can see here, they don't recover activity in the whole brain. In other words, you don't need the whole global brain activity for you to be aware, and we could use voxel-based statistical mapping to identify which parts were really critical for awareness. So we've been publishing and using AI classifiers for many, many years now, showing that this is the global workspace that seems to be critical for you to have conscious awareness. And you see here, using fMRI, a breakdown in the midline internal awareness network that overlaps with the default mode network that would be identified later. And you see locked-in syndrome, minimally conscious state, vegetative unresponsive wakefulness, and coma with this breakdown of functional connectivity when you have a reduction of awareness. And there is a critical hub that is very important. It's the most connected part of your gray matter. It's the precuneus and adjacent posterior cingulate cortex that seems to be one of the first areas that recovers when patients go from vegetative unresponsive wakefulness to minimally conscious state. So if I would summarize the past 30 years of our research is that you have this global neuronal workspace that disconnects when you lose consciousness in slow wave sleep, in general anesthesia, in coma. You see, it's really not just one spot, it's bilateral, the front, the back, the left and the right, prefrontal, temporoparietal, both at the convexity and midline, as said, precuneus, posterior cingulate, and mesiofrontal, anterior cingulate areas. But what is very important, I think, that in all cases here, we look at reductions of wakefulness, whereas in unresponsive wakefulness or vegetative state, it really helps us to identify the neural correlates of awareness, because here patients are awake, eyes wide open, yet lack any behavioral sign of awareness. And there you again see that global temporofrontal parietal network that breaks down, similar to what has been shown in complex partial seizures. These are SPECT studies, absence seizures in fMRI, or sleepwalking with SPECT again from Claudio Bassetti in Switzerland. So very important that we identify the awareness networks and decode the activity to translate it to clinical reality. And now we have, of course, tools using EEG to look. This is an auditory oddball paradigm we use in intensive care, published in Science now many years ago, where we use dynamic causal modeling. And then you look at not just connectivity changes, but the directionality of the connection. And it seems to be the case that for you to be aware of what is being said, auditorily presented, you need that top-down feedback connection from the higher order networks of the frontal parietal awareness network to the lower order, in this case, auditory, I would say, slave systems. Primary auditory cortex, sessile gyrus, and then secondary auditory areas, which we saw that top-down connection only in healthy volunteers or locked-in syndrome patients or minimally conscious state patients, but not in coma, anesthesia, or vegetative unresponsive wakefulness. And that can be done at a single subject level. So we kept working at all those possible assessments, both using EEG, but also, as said, PET imaging and structural and functional MRI. This is one paper from a couple of years ago, made the cover of Annals of Neurology. You see high-density EEG connectivity in the alpha band that breaks down when you compare conscious controls, intermediate in MCS, and then it's low connectivity. This is the long-range Mohawk connectivity breakdown in alpha, and you see increase in pathological delta activity. And when you see what's in the MCS star condition, these are patients that were sent to our center in Belgium with the diagnosis vegetative unresponsive wakefulness. But it turns out that the EEG connectivity tells us otherwise. They are also called now cognitive motor dissociation. So at the bedside, it seems everything was just reflex, but the complementary objective testing here with high density EEG connectivity showed us more was going on. And that's also what we saw in glucose PET imaging. You see in the left upper corner, there's these islands of cortical activity. And also with voxel-based morphometry, we could see preserved brain structure and function. And in those cases, we could next show that you can push it and decode the activity to make it into a functional communication. So it started with the science paper together with Adrian Owen. 2006, we asked patients to do something like imagine to move. They were not moving by controlling their muscles, but they were activating their motor areas in the fMRI. And then we had the first patient that was sent to my center in Belgium with the diagnosis vegetative, came from abroad, massive traumatic brain injury. You can see the MRI here with secondary hydrocephalus, not a lot of cortex left. But when we asked him to imagine playing tennis, he activated premotor areas. When we asked him to do something else, like walking around in his house, spatial navigation, he activated parahippocampal areas. So you can decode that when you explain to the patient, and we did that, we know you're conscious, we're going to ask you questions. If you want to say yes, do spatial motor imagery, motor imagery. If you want to say no, do the spatial navigation. And then you can decode, you say question 1, is your father's name Alexander? He's doing the motor task, decoded as yes. Is your father's name Thomas? He's saying no, we see activation in parahippocampal areas. Question 3, saying no. 4, yes. 5, no. And then question 6, because this is very attention demanding, probably exhausted, we had no reliable EPI Bolt signal. Of course, this is very hard to do in our center. We do it for decades. About 40% of the patients, we could not get sufficient high-quality data because patients move or there's artifacts from respiration or other that make it very difficult to decode. And of course, EEG is much cheaper, easier to reproduce, and so we work with these brain-computer interfaces, and the company GTech, the only one to propose a plug-and-play, they call it MindBeagle BCI system, specifically for disorders of consciousness. So that is wonderful to be able to use these technologies, and yet in a number of patients, we know they should be able to answer with the BCI, and they do not. And we know also from clinical reality that there's these fluctuations in awareness, and we capture that with long duration EEG, a very simple spectral entropy measure worked by Andrea Piroli, who was with us now in Italy. And you see that in MCS and in that category only, not in vegetative unresponsive wakefulness, we would see those increases in entropy about every 70 minutes. So you have that ultradian rhythmicity that I think is very exciting, and we should increase our efforts to target those windows of opportunity, both for diagnostic assessment and decoding for communication or also therapeutic interventions. Now, the challenges are multiple, so we need to go multicentric to generalize the findings, which is what we did together with our colleagues. This is a paper with Nicholas Schiff from New York and other teams where we have support vector machine classifiers at the time, decoding resting state fMRI and giving us a information about diagnostic probability to be MCS or unresponsive. And also, as we showed, that has prognostic information. We also, with the team of Marcello Massimini from Milano, applied EEG TMS, testing Giulio Tononi's integrated information theory, which basically says that for you to be conscious, the information needs to be integrated, and you can put mathematics behind that. If you perturb the brain, in this case with TMS, stereotactic transcranial magnetic stimulation, and you read out simultaneously the electrical echo, you can quantify the complexity. In this case, we use Limpel-Ziff, and you can reduce the capacity of the brain for consciousness by what we call the predational complexity index. If it's high, we saw that in conscious wakefulness, locked in, minimally conscious patients, and it was below 0.3. This was only observed in slow wave sleep, anesthesia, or truly vegetative unresponsive wakefulness patients. And that works at the single subject level again, even in patients who are aphasic, who don't understand the questions when we have a brain-computer interface, or who have sensory deficits, who can be deaf or blind, or motor damage, making this test very, very interesting. We kept looking at many different approaches. This is again AI-driven explainable consciousness indicator, where we looked at sleep, anesthesia using ketamine, propofol, xenon from our center in Belgium, and then the disorders of consciousness. Won't go into the details, but it's fascinating to see how, of course, AI is truly helping us to make sense of those time series. And then we cross-validated, as just mentioned, between pathological coma in related states and then anesthesia. There's a number of papers by our team using different anesthetics, and every time you see this breakdown of the global workspace connectivity, the external and internal awareness networks, and it's not at the so-called sensory slave system. So you see here, when we give propofol, you see wakefulness, mild sedation, unresponsiveness, and then recovery of consciousness when we stop propofol. And you still see connectivity in visual areas, in auditory areas. So truly where it happens is not in those lower level areas. It's truly higher order multimodal associative areas. So if I would summarize again all of those results, it points into the direction of the hypothesis that awareness can be again reduced to two dimensions, which is external awareness, and those are seemingly critically dependent on the functional connectivity in the lateral temporal-frontal parietal areas, and then internal or self-awareness, which seems to depend on that midline core overlapping with the default mode. So we tested that in a number of projects and papers. This is one here where we had healthy volunteers in the fMRI. So this is no active task, but you can't help it. If you're laying there in the magnet, you're thinking. And we asked them, they heard a beep, to score whether they were more externally aware or internally, meaning they were thinking about what they would do tomorrow, or what happened at breakfast, and so on and so forth. And you then correlate those scores with EPI bold, and you see, again, as predicted, lateral in red, frontotemporal parietal, when they were increased external or sensory awareness, and in blue, the midline core, when they had stimulus independent thoughts. And also at the behavioral psychometric level, you see in this paper from Journal of Cognitive Neuroscience a anti-correlation, both at fMRI bold, but also at the psychometric level. It can, when you're more paying attention to what's coming into your senses, you have reduced stimulus-independent thoughts and vice versa, with a frequency of about 0.05 Hertz. It can be disrupted in a number of conditions, such as hypnosis and meditation. And we published extensively on hypnosis, which we also use in our hospital. You see neutral, normal consciousness, then distraction, and hypnosis, where we have a difference in the scores for absorption, dissociation, and reduced external awareness when you are in this hypnotic, dissociated, absorbed state that is characterized by a breakdown of the external awareness network, as you can see with fMRI. We also showed that the activity of both external and internal awareness networks actually impacts how we perceive the world. This is a paper by Melanie Boli. At the time she did her PhD with me. Now she's professor at medicine Wisconsin, and she had the idea to monitor using fMRI the external and internal awareness networks while giving a laser stimulus. And she made the intensity such that about half of the stimuli were not consciously perceived. So they would get the laser somatosensory stimulation, and then they scored whether they perceived it or not. And actually, by monitoring the external sensory awareness activity, she could predict that when that was up, they would perceive it. And when the internal awareness network was up, meaning midlight core, it would go unnoticed. It was later also shown for the auditory modality. We also use the patient own name. So in intensive care, it's very important, as has been shown for anesthesia, to talk to patients with their own name, because it activates the internal awareness network. And we have a number of papers also with our colleagues in China. So all of those are very important because we've repeatedly shown that just clinical assessment at the bedside can lead to misdiagnosis. We have shown that 4, even 6, 7 times out of 10, our clinical diagnosis can be corrupt, can be wrong, especially if we do not use adapted, validated scales. Historically, the best one, it's not the Glasgow Coma scale, that's a Coma scale, doesn't work when patients open the eyes. The 4 is an improvement, but it's not specifically designed to identify MCS. The Coma recovery scale, I think, is very, very good, but takes time to learn and to do. And that is why, especially after we've showed that you need to assess patients 5 times. You can't go into a room, do your Coma recovery scale, and say he's or she is vegetative or unresponsive wakefulness. You need to repeat the exam at least 5 times, but that takes time. So we developed the seconds, and I'm very, very happy that you're currently working on the validation for India. The simplified evaluation of consciousness can be done and is quick to learn. So the philosophy is do less more frequently to reduce the diagnostic error. So we specifically look for those signs: eye tracking, orientation to pain, response to command, that are typical of MCS minus, MCS plus, and functional communication. Of course, some of these patients would still need functional neuroimaging. We've shown, this is a Lancet paper from now over 10 years ago, within 130 patients. This was monocentric, our Belgian cohort at the time. About 32 would have a misdiagnosis, even if you do the repeated 5-day assessment. So clearly there is added value for PET, fMRI, and EEG passive and active paradigms when dealing with chronic disorders of consciousness. It helps us to reduce the diagnostic uncertainty, the prognostic uncertainty, but also, of course, can have therapeutic consequences. And this is a very old paper, Lancet 2000, where we showed that patients with unresponsive wakefulness suffer from thalamocortical disconnection, and that they recover functional interaction when they recover consciousness. We identified the intralaminar nuclei that were exactly the target of Nicholas Schiff bilateral deep brain stimulation, helping recovery of awareness in a post-traumatic MCS case published in Nature Medicine. And now this is also what we do with our colleagues in China, Beijing, with recent Nature Communication paper on the importance of thalamocortical dynamics and stimulation in the recovery of conscious awareness. In Belgium and Canada, we've very much focused on non-invasive brain neuromodulation using transcranial direct current stimulation, TDCS. We were the first to do controlled clinical trials with anodal 2 milliampere, 20 minutes left prefrontal stimulation, really showing that it can increase neuroplasticity and cognitive recovery. And now it's very fascinating times, because on top of deep brain stimulation, TDCS, we have low intensity focused ultrasound, we have transcutaneous auriculovagal nerve stimulation, we have temporal interference next to the pharmacological studies I didn't mention, but amantadine, zolpidem have been shown to help patients, and I think definitely combined with BCIs and robotic rehabilitation, the field of rehabilitation is changing. So a number of papers where we again decoded EEG BCIs, here asking patients to move their foot, move their hand. They're not moving foot or hand, but we see, and Penfield, homunculus, that there's more midline activity when they try to move their foot versus when they try to move your hand. And then the challenge, of course, to avoid both false positive and false negatives. This is why we keep cross-validating it with functional neuroimaging. You see a paper here where we show that covered command following was present in those who have residual neural glucose metabolism. In the end, of course, we do this to offer patients a better quality of life. We don't know what it is to be minimally conscious, but we've extensively looked at quality of life in locked-in syndrome. This was a study with the French Association for Locked-in Syndrome, and you see very surprising results. We shouldn't judge a book on its cover. Many of our patients in the cohort scored high on subjective well-being. Also, of course, as seen here, some scored -5 with the demand for euthanasia, which are very complicated ethical discussions. But it is important to do. It is important to keep this kind of research, decoding brain activity in disorders of consciousness, because it matters. When you identify signs of consciousness, your approach would change from day one. We've shown, for example, that they can perceive pain by applying noxious stimulation and doing functional imaging. We saw the whole pain matrix activating. This Lancet Neurology paper, activation of brainstem, thalamus, primary and secondary somatosensory areas, insula, anterior cingulate cortex. So part of the pain matrix that is definitely important for the cognitive emotional component of pain. In other words, as soon as you are confronted to chronic disorder of consciousness, check for residual pain perception and give appropriate pharmacological treatments. Just a couple of words on near-death experiences. So these are the patients who are not brain dead. It's very important. We have still some residual, even a very abnormal brain activity, and afterwards they would share their very incredible stories of seeing the light, this notion of well-being, these out-of-body experiences. And we've compared it, number of papers here, with thousands of people who took psychedelics, and then what neurotransmitter systems those psychedelics and other psychotropic drugs work on. And we showed that drugs like psilocybin or ketamine are very close, when you look at the subjective phenomenology of the reports, to what we observed in classical near-death experiences. So very, very happy to meet you all here virtually, and looking forward to collaborate, because I think the true challenge now is to translate everything I've been discussing, understanding neuroplasticity and disorder of consciousness, to better clinical care. And truly now we know that neuromodulation coupled to robotics really impacts recovery and quality of life. We collaborate with many centers. This is a private center in Belgium and the Netherlands called Trainem and Brainem. It's just a question of who pays for this. And I know, of course, in India, there's major challenges. And that is why I think we need more multicentric collaboration to really adapt this to the practical possibilities of each and every hospital. But the old dogma that there's nothing we can do for none of these patients who survive coma but take more time to recover is simply wrong. And also the neuroplastic changes, we can see them months, sometimes years after the injury. This is just a case series. You see case 1, 20 months after TBI. Case 2, 10 months. Case 3, years after hemorrhage. And you see using both PET and MRI that there are changes, both structural and functional, that parallel the recovery seen in patients. Just a couple of words of meditation, and I know that this is part of your culture. For me, it was an eye-opener to work with Buddhist monks. This is Mathieu Ricard, the translator of the Dalai Lama, who came to my center in 2015. It led to a number of projects. It's also a book that became an international bestseller, the no-nonsense meditation book, Scientist's Guide to the Power of Meditation. And as a neurologist now, this is outside the disorder of consciousness pathology I see, but now would prescribe mindfulness-based stress reduction. And when you decode the brain EEG activity, this is low density. You have a decomposition in 130 components. You see the temporal dynamics, the brain creating thoughts, perceptions, emotions, and the artificial colors switching from one to the other, the so-called monkey mind. And then when these lamas and Zen masters from all continents, including India, Himalaya, China, now also working with the North American indigenous traditions, you see the switch. So you have that stability in the EEG activity with some burst of high frequency gamma-like activity, but really very, very impressive how meditation is like mental gymnastics and can basically be done by anyone. This is a TEDx I gave with my daughter whilst she was wearing the EEG monitoring, doing breathing meditation on the scene, helping to better deal with anxiety, sleeping problems, depression. We also work with top athletes. We published The Brain of Guillaume Néry, the world champion of apnea diving, high-density EEG decoding. We work with Olympic athletes. Another study with the gymnastics of the Israel team, where the power of the mind in top athletes is very, very impressive, and their capacity to focus, to do mental imagery, to deal with distraction. Also, the studies we do with artists, and I work with Toyota R&Ds, got nothing to do with AI, the creativity of the human brain that can really lead to incredible artistic performances. And again, we are decoding that activity. As for the entrepreneurs on the 3 continents, we have thousands of entrepreneurs that were part of our study cohort, and many of them were assessed by EEG and MRI. And it turns out that cognitive flexibility, the capacity of your brain to deal with change, is crucial, and we link that to activity and connectivity of the insula. For many years now, we study the brains of astronauts and cosmonauts. That is an extraordinary opportunity to see the impact of zero gravity, but also pure performance and resilience up there in the International Space Station. With that, I thank you very much for your conscious awareness, I hope. Look forward to your questions. And of course, I thank very much the Coma Science Group and GIGA Consciousness Research Unit in Belgium, the Canada Excellence Research Chair in Neuroplasticity in Quebec, CERVO, Laval, and the colleagues from the Chinese Academy of Science and Hangzhou Normal University, and all the families of the patients and patients themselves, part of MindCare Foundation. Thank you very much, and I look forward to your questions and reach out if you're interested in the multicentric collaborations. As said, that's where I think we need to put now our efforts, because it's not just about publishing papers, it's about really translating that to hospitals all over the world. And also we have free positions in the labs of the 3 continents. Thank you very, very much.
Thank you, sir, for such an amazing talk. So usually keynote address do not take questions from audience, but I think as we have you here, if you could take 2 to 3 questions from the audience, that will be great for us.
With pleasure, Sean. Thank you.
Yeah. So if anybody in the audience has a question, you can unmute and ask.
I see Arya is raising.
I have a question. I have a question regarding the coma scale that has been used. How effective is the newly upgraded coma scale in the matter of research?
So we published a number of validation studies of the seconds, the simplified evaluation of consciousness scale, as compared to the coma recovery scale, which I think is the gold standard when it comes to disentangling vegetative unresponsive from minimally conscious state patients. So we now, in the new studies, use the seconds, and as said, we should aim for at least 5 assessments, because there is intrinsic to the MCS condition this variability and fluctuations over time. So that's an important message, that we should really see people multiple times before we make a formal diagnosis. Is that answering your question?
Yeah, it does. But is it possible that the frequency is somehow reduced by updating the coma scale?
Oh, well, one should look at that. So I think it's a scientific question. So we're now in China working with what is the biggest database in the world, with many, many thousands of patients longitudinally being repeated over time, and to try and answer your question. There's many variables, of course. It's going to be different for anoxic versus non-anoxic traumatic hemorrhage. It's going to be different for children. Sedation, of course, in the acute, subacute plays a role, and the anti-epileptic and the drugs we give against spasticity, that also can impact the attention and arousal. So you're right that 5 is kind of this current target that seems to apply for most of the patients, but I think we can be more precise, and therefore we need, given there's so many confounding factors, more patients, and that is work in progress. And we would be very happy, and I look forward also to the results of the studies led by Sean in India.
Thank you, sir. It answers my doubt.
Hello.
Hello.
Yeah, thank you, Dr. Stephen, firstly, for such a fascinating talk. My question was in relation to athletes, specifically the long distance endurance athletes. I've watched quite a number of interviews of them, and many of them describe their brains basically going dormant during certain phases. They may call it zoning out, or some may even call it the flow state, where their body just keeps on going while they have like reduced awareness. And so I'd like to know what happens to the brain during this phase.
It's a good question. I don't have the final answer. I think one is measuring EEG in those conditions, which is tricky. So I ran a marathon with simultaneous EEG monitoring, which is, as you know, not easy because there's movement artifact, sweating, and still that's what we're going to see more and more, just as athletes now use their heart rate monitoring to define and optimize their training. I think the mental component is so important, and it's not easy to quantify. You say flow, which definitely is this incredible state where everything seems to go like automatic. We've also seen it in rock climbers. This is again an activity where you're by definition very mindful of the here and now and not having distractors or thoughts going anywhere. It's not easy to talk about reduced awareness because I think it's multidimensional, as said, and we should, and that's also a work in progress, increase our efforts to better document the specific phenomenology of this athlete at this given moment in time, which is very hard because there's not there's no neuropsychologist doing interviews while they are going through their you mentioned ultra runners or so it's not easy. We use microphenomenology, which I think is a wonderful tool now, couple it to AI, to really help us, not just to look at EEG, but to look at what is that person, athlete or otherwise, experiencing right now, and then do our cross correlations. And I think we've kind of neglected that. And again, your country is much more rich and open to historically the study of conscious awareness, whereas I think that since behaviorists, Skinner, Pavlov, in reaction to big pioneers like Sigmund Freud and Jung and the father of psychology, William James, who were very interested in personal, private, subjective phenomenology, we maybe, and also in our excitement about fMRI and the sexy brain mapping tools, we kind of neglected the pure phenomenological part of it, and I think we need to correct that.
Thank you.
Hello, sir. I had one more question. As we all know, music is a stimulant to the brain. So, can it be used in the treatment of coma or in the treatment of vegetative states?
Can you repeat? I'm not sure I got your question. Sorry, the line was not good. Can you repeat?
Yes, sir. As we know, music is a stimulant to the brain. So, can music be used to treat comatose patients?
The question is about music?
Yes, sir.
This is a very interesting question, and you're absolutely right that music is extremely powerful because it touches our emotions, and it doesn't need also linguistic comprehension. And as we've seen, and we published that MCS minus actually seem to suffer from left lateralized hemispheric damage encompassing the language network, and music can overcome that. So we published that if you present patients' favorite music, and we did that in the fMRI, you see a unique increase in functional connectivity. So you're absolutely right that music is very powerful. We also know from clinical reality that music therapy can be beneficial. We use it in Parkinson, we use it in dementia. It's hard to find good quality controlled studies in disorders of consciousness, but I do think that the neuroimaging studies do show that music is a very powerful stimulus and that we should increase it in also clinical settings.
Thank you, sir.
Okay, I think in view of time, we can stop the questions. So thank you, sir, for attending us and attending the invite and coming to us for giving the talk. And also, we are also excited to have the multi-center collaboration with you on second scale. So thank you for accepting your invite and coming and delivering a comprehensive talk. Thank you, sir. Thanks a lot.
Thank you very much and enjoy the rest of the webinar series. Very impressive program. Thank you. Looking forward to come to India later. Bye-bye.
Thanks.